Zo. Yeah, it should work. And if I do this, I have to do this, I think. Now I see Bogdan,
Yeah, hello.
Faras, Sinan. Hi, Kawin.
Hi.
Charlie. I'm not sure if this works that I have to put everybody in there. Let's see. I hear myself. How does it work? Can somebody else talk?
Hello. Hello, can you hear me? This is Faraz.
Yep. How does it work? Sorry, guys. Just have to see how it works now. I think maybe somebody has their audio on or something. Maybe you should have earphones, or because this doesn't work well.
Should we all mute apart from you, Neil?
Yeah, let's do that. Hello? Hello?
Yep.
That's better. Yeah. That's a bit annoying because we should be able to have a discussion, of course. But all right, let's start. First, we will have introductions, and then we can talk about Charlie's case study. And if it all works, Sinan also had a little summary about the new back pain guidelines. So we can also talk about it. All right, and Faras, I have to say, I love your shirt.
Thank you very much.
Looks very good. Next time I will also have my t-shirt on, but this time I forgot. All right, so welcome everybody. Let's see if I can see the chat also. Yeah, hello from Romania, Greece. Could everybody let us know in the chat where you're from? It's always nice. Yeah, and this is the first time, so sorry about all the problems. Amsterdam, that's a great city. All right, so my name is Niels Oudhuis. I will start. Creator of Trust Me, I'm a Physiotherapist, and co-founder of Trust Me which is like a Netflix for physios. And it's an educational platform for physios. And I live in Amsterdam, in Holland, the Netherlands. And I have studied manual therapy also, a master's, and did my physiotherapy degree in Amsterdam. And now for the second time, the live streams. So we did it already in 2017, and we recorded a few of them and put them also on TrustMed, so you can rewatch this. And this will also be saved or recorded, and on the Facebook page and the YouTube page, you can find it back. Hopefully, we can maybe cut out the first 3 minutes. Yeah, we are here with a team of podcast hosts or live stream hosts. And we're going to be discussing all kinds of things about social media or about physiotherapy, and a very open and practical discussion. And We live in a very polarizing world now, and with heated debates on social media where everything is black and white. And I think it's not so black and white most of the time, it's more complicated. So, yeah, we can discuss this in a more long format and see where the gray part is, which is the most interesting, I think, and see how we can learn from each other and see how we can really practically improve. And that's what it's all about, of course. And ask each other, how are we actually doing this in your clinic? And yeah, this is really interesting, I think. Instead of more the research and the theory, it's a bit boring. You cannot really practice this in your clinic. So yeah, this is let's focus on this. All right, good. This is a short introduction. Let's go one by one with the podcast team. Faraz, could you introduce yourself?
Sure. Hi, everybody. Good afternoon, good evening, good morning, wherever you may be joining from across the world. My name is Faraz Sethi. I'm a British physiotherapist and I'm in my 17th year of clinical practice. Thank you for Niels for organizing this platform, and obviously Trust Me Ed for trusting me to be one of the podcast's hosts. And like Niels has already alluded to, it's about open discussion. It's about no right or wrong answers, no stupid questions, and just learning from each other. So the podcast hosts will learn from each other, and all the people, whether you're a student, whether you're just a fresh grad, or whether you're a really clinically experienced physiotherapist, there is always room for clinical learning, critical thinking, clinical reasoning, and that is what I think is important. And like I said, most important, there's no right or wrong answers. Let's learn from each other and let's have a bit of a giggle and a bit of a laugh. That's the most important thing about being a physio.
It's very true. Bogdan.
Okay, hello everybody. I'm very honored to be part of this wonderful multicultural team. My name is Bogdan Goga. I'm a physio from Romania. I'm very passionate about our profession, and I am implicated here in Romania in a lot of projects trying to develop this wonderful profession. I'm a big fan of Trust Me Ed. I don't know, since 4 or 5 years I watched it all the time, and it changed my clinical practice. I hope we're gonna have a nice afternoon here. It's around lunch here in Romania, so we're gonna have we remains a nice lunch edition. But hello to everybody, and I hope after this session and after the others, everybody can improve just 1% or 2% their clinical practice, and that would be a really gainful addition.
Thank you. Sinan. We don't hear you. Damn it. No, we don't.
Now?
Sorry, we don't hear you now.
So now I'm a physiotherapist in Australia, practicing for about 10 years now. And I echo Niels' our profession has got. I think the day where all physiotherapists will get better, and I for everyone to come up with solutions to help people. I've been working for about, like I said, and I'm interested in pain and either workers' compensation system.
Thank you, Sinan. We had a little bit of a problem with the sound. We had also last time already with the practice, so maybe you can change some things with your Bluetooth or whatever. I'm not sure. Kavin.
Hey, can everyone hear me?
Yep.
Perfect. Yes. Hello to everyone out there in the world. I'm from Hamburg. I'm a German physiotherapist. And I started actually to work as a physiotherapist in Berlin, 2020, 1920, and moved to Hamburg since the pandemic, actually. And yes, I studied in Germany, and my focus was always body performance because I was for a long time a dancer. So body performance was like basically the posture was always very important for me. And because by an own accident and visiting a physiotherapist, I came to the idea to study that. And yeah, so I work since 3 years now as a physiotherapist, so I'm a junior. But I really enjoy to exchange with everyone because I truly believe that you exchange with other people, that you learn more and more because they're out there, different techniques. And even when I translated for Trust Me Ed, that's how I came to Trust Me Ed, the subtitles from English to German. I even learned and so much by watching the videos. And yeah, last year I was doing my seminar as a mindfulness coach too. So communication and performing and also doing exercising to combine the whole thing together became for me very important. And I realized how important it is to be aware of your body and to be your own good therapist too. So that's why I try to explain as much about the anatomy in the beginning, ask them as many questions that I can, and also try to give them the feeling to trust me too. So basically that they can't give me any like wrong answers or questions where they have to be feared or anything. And yeah, so I'm really, really thankful, Niels, to and all of you to know you and to exchange and have really nice podcasts in the future. And it's also nice for everyone else out there who's listening today, because it's basically for free to listen to and get as much information to, be your own good therapist. So thank you.
For sure. There are many topics we can cover, so that would be great. Charlie, if you can put your video on. Charlie? Ah. Hey, Charlie?
Sorry, I'm having.
I don't hear you.
Hello,
Now I
can you
hear you.
hear me?
Yeah.
Sorry, I'm having.
But there is
you hear me?
some.
Okay. Is that better?
A bit, yeah, a bit.
Can you hear me better now?
Yeah.
Yeah. There's a delay, but
I
yeah.
might just have to change the audio slightly. I've just had to. My laptop's not working today, unfortunately. Okay.
That's right.
Is this working okay?
Yeah, there is a
All right.
delay,
So,
I see,
hello
but
everyone.
that's
My
fine.
name's Charlie. Apologies for the technical difficulties. And I'm a musculoskeletal physio primarily. I've been in practice for 12 years now. I work in private practice and also work in sports. So I've always enjoyed. We can all have good discussions today and help others learn, as well as us learning ourselves. I think it's a really great platform for us to really share our thoughts and ideas. And I'll be sharing a case today, as long as hopefully we can all enjoy this process over the next couple of months.
For sure. Look. There we are all. Right? Do I have everything? Yeah. Maybe this is a bit nicer that everybody is there. Yeah, Charlie, maybe you can find some way to uh, to improve your stream, because you are the patient with the low back pain. But otherwise, I can also be a patient. I have many stories of myself of back pain, a history of back pain, and also a lot of other patients, and I'm sure you all have. So. It's always nice to hear like a patient case study or like a little story about it, and then we can discuss. Okay, what have you done with it or with that person, and why, and all these things. Um,
So is there still a delay my
yeah,
end?
maybe your earphones. Sometimes that happens with the Bluetooth and stuff. And Sinan is also gone with the
Okay.
video. But yeah, so by the way, this is only a part of the whole team.
Is
There are
that
more
better?
podcast hosts. Um, I'm not sure. It's always nice. The live streams and the technical problems, they're always technical problems. I've had many of these Q&A webinars also, and always there are problems. So we just have to roll with it. But yeah, there are more podcast hosts, and you will see them in future live streams. And some of them are already doing their own podcasts, like Bogdan and Charlie. But yeah. Let's first start. By the way, with Kawin, it's always nice to discuss things. I heard you say about posture. That posture is that's already a whole topic. By the way, we can discuss. We can discuss about posture. What are your thoughts about posture?
Now you can hear me, right?
Yeah.
Okay. I think just the picture is now frozen.
Oh.
I'm not sure if anyone can see me.
We can.
Okay, awesome. Then it's just on my MacBook for some reason. Yeah, I mean, everyone's always asking me, like, the patient, is there the perfect posture? Is there a way how I can sit perfectly on the desk in the office? And I'm like, yeah, there might be the perfect, and I mean, there isn't really a perfect posture that you can have. It's more about the diversity, about like the opportunities that, like, I mean, no one can sit 8 hours and just hold one posture. Of course, we can lift up a bit our shoulders, take care about our head, that it's not like leaning too much forward or that
I have to do
activates
this.
a little bit. Yes. But I think it's more give your body as many postures as you feel comfortable with. Of course, it's a bit about presence, like, for example, that's what I learned as a ballet dancer, that you always keep yourself up straight, but it's not just a position, it's you just look more confident also at the same way. That's what I mix a bit with the mindfulness, the physiotherapy, that that's what I really like about the first sessions in the physio. I always look at the patient, how they entrance or how they walk into the room, like where they place their stuff, how they feel, how they sit when they talk to me. And after a while, if they get more like trust and they trust me, I can see the difference in their posture. And that's what I'm telling them. Like, it's about a mix of emotions. Am I stressed? For example, stress is a very important fact for the physiotherapy. Then, of course, I'm a bit more like bended or, you know, like more crunched. And if I feel more confident, I'm more upright, I have a better posture. And all these facts, I think, are very important for the first session to ask for. And that's why I asked a lot how they feel today, how is their work, and even if they enjoy their work or job, because I've had recently 2 patients with back pain, and it came up after a few sessions that the back pain wasn't really important anymore because their job stressed them so much. They were like very tense at the desk. even if they exercised a lot and they had a good fitness, they had a good core muscle, I realized all these all these questions are really important to get them to the point where they can tell you more and more about it, and even maybe cry in front of you, just let everything out. But yeah, if the person doesn't have the perfect posture, of course, I train the core muscles always. And yes, and correct them where I feel it's useful. That's what I can tell about that.
Yeah, for sure. And of course, we don't have to agree with everybody all the time, and everybody has their own way, and that's great, I think. And we can all have our own say then afterwards. Maybe it's a bit difficult with 5 people or 6 people here that everybody has their own say about everything. But yeah, we have to. There will be many live streams onwards, so it will be fine. But yeah, it's very interesting to look at people, and you see so much about them already, like if they're repressed emotions indeed, or how they feel, how they walk, how they move, because they're compensating for something. It is really interesting indeed. Yeah, you can really see a lot already, and we can discuss this in length, of course. Charlie, how is your? No.
You tell me. No?
Now yes, but still it's a delay. Yeah, it's weird. How is yours, Sinan?
Can you guys?
Yeah, it's also a bit delay, but I do hear you. I do hear you.
Okay.
Now, perhaps you can start, Sinan. You wanted to discuss the new back pain guidelines.
Yeah, happy to kick things. I'll try. Essentially, you've got the Australian, a lot of body and government bodies that are constant for management of that are a significant burden. So over the past couple of years, the management guidelines for pain, and the guidelines are on the internet, but I can share with you, Niels, as well. They're quite extensive. They're a very easy read as well. I'll just highlight some of the things so in the guidelines. They focus on 8. So I'll just pull that up now. I'll just give me good enough, or is there still quite a?
Yeah, it's not so good now, and it's like very like this. It just stops and goes again. Maybe we should wait for your connection is a bit better.
Sorry, how I could change it.
Do you have also like earphones with your with like this?
No, I don't think my.
And how's it now with you, Charlie?
Hear me yet? Is it working at all?
I think it's better now, yeah.
Okay. I'm not sure. Our patience was the answer. Okay. Should I go ahead with the case study?
Yeah, perhaps let's move to you now, indeed. Yeah.
Well, the case study was initially one that I had in mind from as of yesterday. I woke up with pretty, so I thought, what better case to use than a personal case? So I'll give you some background. My a radiculopathy about 8 years ago, 11 months. It didn't really change very much at all, and I ended up to me, which completely alleviated my pain. And I've gone on to live a very normal life. I played rugby for lift weights, and have only had very mild flare-up.
Oh.
You're doing so well.
Yeah, you were doing so well, and now it is gone again. No, I don't hear you anymore. No.
Neil,
yeah.
maybe we can just open up the floor to just the four of us who are actually able to understand and hear each other. Maybe we can just open up with a simple discussion until Charlie and Sinan sort their headphones out. Is just basically, what do people understand by the classic diagnosis that we hear these days of specific versus non-specific low back pain? And does anybody like that terminology? Maybe I could just open up that floor to people. What do you think? What do you think, Kevin, and what do you think, Bogdan?
Yeah, so we hear a lot about this thing nowadays. If we read a lot of the articles, so specific, it's specific pathologies like tumors, ankylosing spondylitis, or very, very keen diagnostics, but the incidence is very little. So it's like there was an Australian study, and they've seen that only 1% of the population observed had this specific. The others, because they could not really connect, we cannot really connect imagery to clinical findings, then we call it like non-specific back pain. But in my humble opinion, we should have better ways of assessing back pain, although we know nowadays that we don't have the best way of assessing it, although we see different techniques, different schools, different methods that say this is the way you should assess. And we should have definitely a biopsychosocial approach to really see what is the patient's problem. Because we know that today that low back pain is multifactorial. So we have a lot of factors influencing. We definitely have biomechanical factors, movements, prolonged postures, but sometimes those factors really are not influencing a person's back pain. Maybe it's a stressful situation, maybe it's a psycho-emotional trauma. So we really need to go and have an individual patient-centered care.
Mm-hmm. Do you agree, Faraz?
Yeah, no, I think, Bogdan, you're absolutely right. I mean, that debate continues, and it will continuously continue about specific versus non-specific. I think, yeah, we need to be better in our diagnosis. Do we always need a diagnosis is the question I always ask my patients. Do you always need a diagnosis? Because sometimes diagnoses, as we know, they stick in the patient's mind, and that's what it means to them, that they have a slipped disc, slip, we know that, or, they have a scoliosis of the spine, which could be causing XYZ. So I think a diagnosis is not necessarily important all the time in certain patient caseloads. But this whole, like you said, 1% specific back pain, we can be very, very, how can I say? We know what's happened, whether about a traumatic incident, or whether about a tumor, or spinal metastases. We can be very sure on those. But this non-specific, you've absolutely hit the nail on the head. We need to move away from the biomedical model, in my opinion. I've been doing this for 17 years, and more I'm moving away from the biomedical model, that you have something structurally wrong with you, because we know back pain is a multifactorial approach with multimodal approaches to try to help back pain. My biggest concern about back pain is I have no issues with people using manual therapy or any other modality for that reason. I just believe the narrative that people use these days when treating back pain is not necessarily healthy or accurate. And that's what patients, unfortunately, words mean a lot, right? Where what we say to a patient means a lot. It sticks in their mind. When they leave that consultation room, the physiotherapist just said this to me. So we have to be very careful how we approach people with back pain, and be better at explaining back pain, because, like you said, it's a multifactorial approach.
I think the
I don't know, maybe Sinan and maybe Calvin, because Calvin's obviously a bit more of a younger physiotherapist. Maybe because I know in universities it's kind of like drilled into us. You know, we're almost like told, you know, assess your anatomical position, and the spine must be at 13.6 degrees of flexion or whatever it may be. But I think maybe it's now, well, it's evolving every single day, and maybe Calvin can tell us, as the youngest one out of all of us, in terms of education, what she learned in university and how she approaches a patient with back pain.
Yes, I totally agree with everything what you said. It was exactly like you said. It sounded like in uni everything sounded like a recipe, basically. Like you said, this need to have 30 degree or whatever, and I was like, okay. So when I started to work in Berlin with my first job, I realized you can't use this knowledge to, like, you can't individualize them more with this kind of recipe that I got. I got very confused in the beginning and didn't know how to use the theory and practical. And the more I had a really nice colleague who introduced me in everything really well, and he said, you know what, forget everything what you've learned in uni and start to read researches. And that's why I also came up to Trust the Ad and other platforms to read through it, and realized, like you said, once the patient got this diagnosis, we have in Germany the prescription where they get this ICD-10 code, and next to the code there's basically the diagnosis, and then they stick to this. And even if they got physiotherapy before, like just manual therapy and soft tissues, that's what they want. And to shift them back to something else or new, to tell them, hey, there are like recent studies that this is not really helping. And I mean, if it helped for you, okay, we can continue. But let's try something new out, because you did for a very long time physio. And if you look back, this is, for example, the second year, and still nothing changed. You come back and back. And I mean, wouldn't be ideal to find something for like a long term to get rid of, let's say, the back pain and do something else? Let's try it out, because there will be no side effects by the end of the day. Maybe a bit like sore muscles if you do exercising, but that's, yeah, was a bit weird to, different, especially to, I felt like in the beginning when I start to work that I have to rescue my mind or reshift my mind. But the more I did, I realized I definitely proved more my knowledge, and I could individualize more patient all of that, instead of going through what I've learned just in uni, because the results were low or no changes. So I totally agree with you, Faraz, that I think in unis in general, maybe they have to change something. I don't know how it is in other countries, but in Germany, unfortunately, there's not much. So that's why I try to find more researchers and stuff out there, like in the world, to find the differences and to find out if there's more beyond just this kind of structure that you learn and can't really use.
Yeah. Yeah, don't get me wrong. I think learning anatomy and physiology is imperative. Don't get me wrong, but I think it's just the way we interpret that and apply that in clinical practice maybe can be improved a hell of a lot more, to be honest. But yeah, that was just a question I opened up with Niels. I'll back over to you, Niels, if you want to go anywhere else with this.
Well, we can go so many ways, of course.
Yeah.
I just wrote down two things what we can discuss, are you afraid of back pain yourself, and do you actually portray that to your patients? And what do you think is really going on in the back then if somebody has back pain? And how would you explain what back pain is to your patients? Maybe we can discuss this. How would you explain back pain? Like a normal acute back pain, I would say, or maybe chronic back pain if you want also.
No, I'll stay away from the chronic back pain, to be honest. It's not my forte, to be honest. But yeah, so I mean, look, acute back pain when somebody comes in, I mean, like we've been told, we have 2 years. Let's listen to what their story is and respect their levels of pain, whether it's psychosocial, whether it's in the head, as people say. I mean, pain is real, but people interpret it in different ways, right? So we have to validate their pain. That's the first thing I would say as a physiotherapist, is validate their pain experience. Let them talk to you for the first 6-7 minutes, and usually they will tell you the diagnosis by just whatever they're saying. I just feel that Neil was asked, how would you explain back pain to a patient? Well, I would exactly say what I just said, that it's a multifactorial approach. So let's say you've had an acute back spasm, woken up this morning, you got out of bed, and all of a sudden you can't move. You're stuck in, I don't know, a fixed flexion or extension, whatever it may be. I would generally explain and say, this could be an array of things happening, not just a protective muscle spasm, and sometimes a protective muscle spasm is a good thing, preventing things from getting worse. So, I mean, I will always investigate their history, any relevant red flags that obviously we need to rule out straight away, any differentials that we need to rule out straight away, anything that could be masquerading these kind of, your back pain things. So I believe, talking to them, asking out, because I've seen patients last week, for example, who come to me and said, my father died 6 months ago. Let's just say that I'm still in the bereavement phase. I'm still in the grief model. I've lost my job last week, etc., etc. My child has had her child taken away from social services, for example. And I'm thinking, whoa, what's going on here? Do I actually care about your back pain right now, or do I think about your general well-being and the other levels of stress that may be surrounding your back pain? So I think it's very important to understand a patient, validate their experience, and yes, we're not going to say that you're not in any pain, but I think the muscle spasm of the lower back and the movement becomes a bit secondary when they've got all these other multifactorial approaches coming abroad. But general acute back pain, I would say, as we say with everything, movement is medicine. So graduated, progressive movement, trying to get into those uncomfortable positions slowly but surely. But of course, as the great Greg Lehman says, excuse my language, calm shit down, build shit back up. So, I think let him calm down for 3 or 4 days with some anti-inflammatories or just some rest. But then, get moving as soon as you possibly can is what I would say to my patients all the time. Unless I feel there is something structurally or something more medical going on, then you look in an onward referral path. But otherwise, no, as we know, 98% of back pain is resolved by itself anyway with natural healing and just a bit of rest and gradual loading. That's the way I would approach it.
Yeah, me too. Actually, calms you down, builds it up. That is a very good one. And maybe it's a bit confusing for a lot of physios because we always heard bed rest is the worst thing. You should never bed rest. But indeed, in the acute phase, with everything, you just have to relax a little bit because maybe it's just a signal from your body. Hey, just calms you down a little bit because we have so many stressors, like you said, like so many emotions and other things on your plate. It's going to go somewhere, all these stresses, and most of the time it's not going to in your foot, it's going to your neck or your back. That's what I experienced also. Huh?
Yeah.
What do you think, Bogdan?
Yeah, well, coming back to individual care, I just picked some things that you said and I will try to comment them. We know today that chronic sleep deprivation, so if you have a chronic sleep problem, so you sleep less than 7 hours as an adult, that's a cause of chronic pain or chronic pathologies in general, less than 3 months. So in 3 months, if you don't sleep 7 hours per night. So and sometimes you may have patients, I have patients coming after 3 days of partying at the Black Sea in the summer, and they say, oh, I have a very big back pain. So definitely for them, rest is the case. But yeah, the idea is we should look also, so I really love the discussion because we're from different countries. I agree with what Faraj said, that sometimes a diagnostic can really wear a heaviness and put a heaviness on the patient. But for instance, in countries like mine, I cannot see a patient without a diagnostic. And we in Romania, we are not first contact specialists, like in the UK, also in France, in Belgium, there's, and I think also in Germany, the physio is not the first contact person. So there already the patient will come with a diagnostic. So one of our job is really trying to make that person understand it. It's diagnostic. It is not a problem. That its life didn't end there, because a lot of times they come with a disc hernia diagnostic, or we have it here. To put it, it's the pathology of the disc. It's from a French word, discopathie, and we say discopathie. And this is a very broad term, and people think that their life ended there and they will not be able to do a lot of things. And there really education is important. So explaining to the people that pain, it's a protective mechanism. It's a very efficient one. This is why we should not like it, because it changes our behavior and makes us deal with the problem. And this is why you should not like it. But pain is there to protect us, so we should not really try all the time to get rid of the pain, but really try to understand it, and then from there build it up. I'm an orthopedic manual therapist. I love orthopedic manual therapy, but I think that we should really reconsider what we believe about it. We know that we are not putting things in place. We're not realigning the spine, or we're not putting joints. There are a lot of nice studies with open MRI, grade 1, 2, 3, 4 PAs done. And we see for the cervical or the lumbar spine, there are very nice studies. And we see there that really don't move the spine when you do techniques like this, but you still obtain a pain reduction effect, or a range of motion, a more range of motion. So the idea is what we obtain with these techniques. In my humble opinion, they're just a mean to an end. So you may have sometimes that patient that really, you cannot really implicate him directly to move. So you can use manual therapy or modalities, but they should be only the starting point to get them move again.
100%.
How's Sinan?
I'll try talking. You guys can let me know if you can hear.
Yeah.
How's that
I
sound?
can hear you, but it is still a little bit, yeah.
Loved your approach for us. I love how you try and reframe acute back pain or back pain, and it's your body trying to tell you. It's, from my perspective, I can align it with some, and with acute back pain, my priority is I need to rule a significant pathology. Or you can't really rule anything out completely. I think the key message with acute back pain is the hell out of them. So as much as I want to tell people they are safe to move, they're safe to, that are really important to them. So always is identify any serious, and yeah, if there isn't one, I think time as well, if I can. So we know if it's quite a significant back pain episode, 6 weeks for a lot of their pain to resolve. Also know that for a lot of acute back, actually don't need any help. It will get better. I think it's really important to give them that time frame, expectations about what their recovery is. I guess I think of specific versus non-specific. There was a really good paper out a few about these terminology. There was some consensus on trial strain, so a muscular strain, or a, and it seems like when that was put to patients, they quite liked to give them some sort of structure that they were they could understand, could accept that this is a muscular injury, or muscles, I guess. So if I've ruled out, I hate the term rule out. You can never really rule stuff. Likelihood of a specific pathology is low. Use terminology like a lumbar strain. I will do manual therapy, but I Bogdan's thoughts on manual therapy and that we have about what it is. I guess I'll do what Greg Lehman does down, and I think I will tell my just doing this to reduce, just really, and those will be often my. I don't know how much of that you guys got, but then I probably do.
We got to just.
In my, I think the as we've got to be so careful with our words. So many studies that show that patients.
It's not so clear, so maybe we have to. Of course, you are awesome, and I think you have a lot of great things to say. Only now we just don't feel it, you don't hear it so well. So maybe let's do it. Let's fix this, and for the next time you can. It's better for communication, of course. Which is a shame because what I heard was already very good, but it is like it's not so clear.
Yeah.
One thing I remembered what Bogdan was talking about sleep, chronic sleep. That you said chronic sleep is a cause of back pain, and I'm not sure if that's really like if you can say it like if it's the cause or it's
it's like an implicating factor. We don't really know the cause. This is why it's used the non-specific. Because you cannot really have a cause for it. It's all the time a multitude of factors. But you know that there are some research out there that say that if you have this chronic deprivation, so this chronic lack of sleep, then it's a factor not only for back pain, but for a lot of chronic pathologies, non-communicating pathologies.
For sure.
And there was a nice study. They compared prescribing anti-inflammatories to sleeping 1 hour more for 1 month, and the results were very good in comparing those two types. So
yeah, sleep is very important. Yeah, I heard Kieran O'Sullivan also talk about sleep a lot when I visited him in Qatar. Actually, he was. I saw a few patients with him. He was always talking about sleep.
Yeah.
But the Qataris people have a different schedule of sleep. They're more awake in the night, so there was always a challenge for him. But sleep is very important indeed. Yeah, if you just don't sleep well, you're feeling run down. Your whole body is just run down, and then your bucket is already more full. It's like one factor that makes the bucket more full. Yeah, if you have other stuff going on, then the bucket just overflows, and that's when you feel pain. That's how I explain.
What do you do if you have two? What do you do if you have two small children that wake up in the middle of the night? You can't just throw them out, can you?
It is a possibility, but it is not. Yeah, that's for sure one factor that makes the bucket full already or fuller.
Yeah, I mean, look, Bogdan, great point on sleep patterns are very, very important. Has a huge effect on our mood, on everything, pain wise, just generally, and just getting going in the morning. I mean, I guess I just want to say one thing before we, I guess, maybe wrap up a little bit is basically, I mean, I tell my patients once they've got over the back pain or when we start to get them moving, I think, Niels, you've put it on your Trust Me education platform about the rattlesnake analogy from, what's his name, Lagerman's approach, which is basically, sensitive tissue can become more sensitive if we actually avoid pain, right? So basically, the rattlesnake analogy is fantastic. I have actually a rattlesnake analogy on my wall at work, which just tells patients, look, if you're in the coping zone, the rattlesnake will leave you alone, but if you push out of pain and push into pain, then the rattlesnake will strike you. So, work in this area. I think that's really important. And some people get it, some people don't. And I just use my own. I also use another analogy. For example, if you're on a main highway road driving at 70 miles per hour or 80 miles per hour and your petrol light comes on, I mean, you don't just stop straight away, do you? I mean, you find the next service station 5, 10, 12 kilometers away, you pull in slowly and you put your gas in or your petrol in. So when it comes to back pain, I say the same thing. It doesn't mean a light doesn't mean stop. It just means slow down, modify your activity, give your body a bit of a rest, change your posture, whatever it may be. And eventually you can get going again. It just takes a bit of time. So that's the analogy I use with my patients, and it kind of works with them quite a lot. So yeah, that's just a little pearl that you can possibly use on Monday morning, Cowan.
No, everybody who's watching this. Somebody says physio is lame. Well, thank you for your comment.
He's got to be British, surely. He's got to be British. So direct. Again, I listen. I've had in 16 years of practice, I've had my doubts about what I do. Sometimes we all have. Is it really lame? Are we actually changing something? Are we actually helping somebody? But I think if we understand the role of a physiotherapist in terms of patient education, reassurance, promoting the body as resilient, and guide them with the right tools. It's not like I said, I'm not against manual therapy. I have used manual therapy. I still sometimes use manual therapy. If I feel it's effective and can help somebody move better, I will use it. But otherwise, it has to be educated to the patient that it is just a transient approach with minimal sort of carryover, and it needs to be then reinforced with movement and that sort of self-empowerment in the patient's mind. I am going to get better, and obviously the studies show clearly if a patient feels they're going to get better, they will get better. And if they don't, then generally, of course, they won't get better. So I guess, yeah, it's a funny comment. I wouldn't say it's lame, but yeah, he has everything right to post a comment like that, because maybe he's had a negative experience with physiotherapy, or maybe he's a physiotherapist with negative experience. I don't know, but yeah.
I'm not sure also, but for sure, if you think that you are the fixer and you have to be the hero of the story, that the patient comes in and you have to be the hero and you have to fix everything, then it can become maybe a bit lame or something. That you feel maybe so much pressure on yourself, and then the patient is thinking like, yeah, I just want to have massage the whole time, and you're trying to do different things what you've learned on social media or something. And then it can feel very lame for yourself, I would say. And I've been in that phase, and that's it's much better to see yourself as a guide or a coach. Like indeed, you have more knowledge than somebody else. It's not like you're fixing a car; you're more trying to help each other. Where you have more knowledge, and you can say, okay, reassurance. Indeed, you can show how resilient the body is, how to use self-management tools. And then people get, because people in pain, they are fearful, they are anxiety, they have anxiety, they have worries about their pain. Will it get worse? And if you can reduce these things, that's very helpful and totally not lame. I think it's awesome.
Is there any other comments? I can't read any other comments. I'm looking for some more comments or questions.
Yeah, I can do this. Can you? No, no new comments. I see. This is one, Joanna, one of the podcast hosts also.
100%. Agree with her.
Patient education is key for non-specific. But then what is non-specific low back pain, and how would you actually educate somebody? These are the good questions to go through in also future live streams. We have one more. Bigger one. Well, I don't know about recipes or guidelines, but we were taught to always try to pinpoint and certify the original causes. If you can simulate and replicate a patient's natural environment in casual day, you can hit the problem right on the head, I would say.
Head or heart, yeah.
Hard.
But that I think it's very hard, isn't it, to replicate everything
Yeah, absolutely.
in a clinical practice.
Yeah, 100% agree. I mean, I think, you know, these new guidelines have come out from Australia, September the 1st, 2022, regarding back pain. I mean, look, I'm not against guidelines, but I'm not for guidelines either, or algorithms and things like that, because they're so individualized. It's not a generic thing. So yes, I guess they give us a tool set to use to really make us safe in our practice. I guess that's what they're there for. But in terms of whether I agree with them or agree with every single statement, probably not. And all these algorithms that we have, that, you know, whether it's ankle pain or back pain, or I just don't agree. I mean, you guys might have a different opinion, but I don't agree with algorithms and guidelines all the time. I think they're quite flawed, to be honest, and quite biased sometimes in the research. But that's just my opinion.
Oh, by the way, I didn't read the whole comment. It wasn't shown on the whole screen, by the way.
Oh.
He said many times I got the help of I got to help patients more by looking at them at their routines, and to eliminate a risk factor that trying to replicate the symptoms to make a diagnosis.
Right.
Yeah, it's always good to try to figure out what is the real cause of the pain. Of course, what are they doing in their lives? Yeah.
Perfect. I think that's an hour, Neil. So do you want to carry on, or do you want to reach out next time? What do you want to do?
Yeah, we're going on until 3 hours more. Well, for sure we could, but let's wrap it up. Maybe we have some closing statements or closing thoughts. Kawin, what do you think?
Yes, I agree. I mean, I've heard many really nice and interesting feedbacks, comments, experience, basically everything from all of you. And yeah, so it's really cool to improve their own knowledge, and I think everyone can learn something, especially me as youngest. But yeah, also like with all the experience and cases that we have daily. And one last thing I want to mention, which I forgot to mention, because Niels, you said we are not like there to fixing a car, it's more like guiding them through something. I've had last year a very interesting case. It was more about guiding this person, like you've exactly said. It was a patient with a diagnosed shoulder pain, nothing more specific from the doctor. And like one of you mentioned, I think Botgan said that in Germany, we are not the first contact, it's always the orthopedic doctor. And he was an English patient, and the doctor could speak English and he could understand him. So I assume there was a proper conversation. But he was like just explaining that he has some shoulder pain. And when I checked his range of motion, everything was fine. It was a bit painful when he went to the internal rotation, but there was also like a connection when I saw him in the first physio session, that there was a link between his spine and shoulder, because he always talked about like a nervous sensation above his upper shoulder neck part. And he got in the second session from my other colleague a manual therapy for his shoulder and a bit first and second thoracic vertebrae.
Mm-hmm.
And the third session, when I saw him again, he was like crying in front of me. He was in so much pain, and his wife was also there. And I was like one of the person in the practice who could speak English. And I was like trying, correcting the posture, checking again the range of motion. He said, no, everything hurts so much. And I realized there's nothing I can do. There's nothing I can fix right now. And then I realized, even like as a physio, it's not like, I think I was reading that through something the other day, or maybe it was one of the lectures when I was translating, and I could relate to that so much. Sometimes when we don't know what to do, we also have to be very honest to ourselves that we're not specified in this. And because it's very difficult in Germany to get an MRI appointment, it takes like months, especially when you're not private. I was calling at this time in the session the doctor, and asked for an MRI because he didn't got an MRI or X-ray or anything or an ultrasound. So I was calling, she was like, sorry, but I can't offer any appointments today. I was like, I would never call during therapy session for a patient for an MRI appointment right now. And she was like, okay, we have an appointment. I was like, okay, there are appointments. So while you're holding that up. But anyway, so we got the appointment, went there with a cab and realized there was nothing with his shoulder. It was his spine, and it was a tumor on his second thoracic vertebrae. He got it the same day the surgery. It's now fully recovered. Went back to my therapy session. I was like, oh God, if this never happened, like just act very quick, do something, be there for the patient, because the person is new in Germany, lived since 10 months in Germany, and the healthcare in every country is so different. And just to do that very quick, just give me the realization it's okay to say, now we cut here, and I will send you over to someone who's more specified in this is. And when he went back with a prescription, he got again misdiagnosed. I was like, oh, not again. But that's why I agree with Faraz. I'm not more focusing just on the diagnosis, on the prescription. I listen to the patient and I let them talk. And that's what I want to say at the end of the day.
Well done, Calvin. Give yourself a pat on the back. That was excellent.
I'll do
Excellent.
that for my back.
Excellent clinical reasoning, critical thinking, and communication. 3 C's is what I say. Defines a good physiotherapist. So well done. Keep going.
We'll do that.
That's awesome. And indeed, if you don't want to be the hero, but are humble indeed, then you will become the hero, actually.
Exactly.
Bogdan, what do you think?
Yeah. I think in the beginning of each of one of us' career, and when you really want to prove yourself, you need sometimes, to harness your ego. And this is the period when you want to be like a hero, or this is how it was for me. But then really when you're becoming more mature as a professionist, then you really, understand that you're just there to help a human being. If you can help him with what you know, it's okay. If not, you should find some other solutions for him. So, and individual care, it's so important. I would, just because I don't want to let it on my mind, I'll just come back to your first question, because I have a lot of debates about posture, if it's important or not, in my opinion. And I don't agree with our colleagues that are like becoming extremists. They say that's not good or that is good. We should all the time see the patient in front of us. Yes, we know there are a lot of studies that posture, it's not correlates directly with back pain, for instance. But if your patient tells him, if I sit in this prolonged posture, I get back pain, for him it's relevant. We know, for instance, if you have scoliosis, I work with a lot of scoliosis patients, there is no clear indication that scoliosis causes back pain. But we know posture is important in scoliosis patients, especially if they are adolescent or infants with scoliosis, because their posture will aggravate their scoliosis. So you see, having an individual way of seeing and understanding your patient, firstly, listen to him, and then see what are his goals and trying to collaborate with your therapeutic goals, I think it's a key. Definitely we should stay with the scientific part of it, but the scientific part of our profession, but we should never forget that our profession is named, it's created with 2 words, physio and therapist. And a therapist should be a person that, in my opinion, it's there for other human beings.
For sure, it's always more complicated than what you can see only in research. Sometimes it's also maybe a bit black and white indeed. And yeah, there's also another topic, research, and posture is a whole another topic. Let's have some have some streams on that. Yeah, it is. There's so much to talk about. Um, um, Now we have one more question actually. Do you think emotions are relevant to bad posture, neck, shoulder, and hip pain? The cure needs to address both. Yeah, I think emotions are very important in especially spinal pain actually, and spinal, which is also hip and shoulder pain actually, because all these muscles also tense up for your in your shoulder. So I think for sure. But yeah, that could also be a whole different topic with maybe with bring in an expert and talk about it. What are your closing thoughts, Faraz?
Yeah, I think apart from the technical difficulties that we've experienced today, which is normal, I think it's been a great little conversation for an hour or so, and it's great to hear from people from different backgrounds, different beliefs, different educational backgrounds, different schools of thought, and I think it's important that we have people like Calvin. No disrespect to Calvin, I mean she's younger, but that's great because we learn from younger therapists, and she might learn something from me, and vice versa. And I think it's really important that we go away with that thought that when it's back pain with patients, it's just about the education and an understanding that you don't need MRIs all the time, you don't need blood tests all the time. I mean, and usually it's not serious, and it will settle down with a bit of reassurance and a bit of progressive loading. I think that's the most important message we can get to patients. Of course, there are always exceptional circumstances that we have to obviously take into a bit more detailed. I'm very lucky in that approach because I work as a first contact practitioner, or APP, which is an advanced physiotherapy practitioner, which means I see patients who either self-refer or just come from their GP, which means I can then put them on the relevant clinical pathway that they need, whether that's mental health, whether that's social support system, whether that's bloods, whether that's imaging, whether that's just physiotherapy referrals. So I'm lucky in that respect that I see them and I can guide them appropriately and I can avoid all these unnecessary costs to the NHS or whatever it may be. So in that respect, I'm quite lucky. And I think that's something that England have done really, really well, or United Kingdom have done really well, saved a lot of money for the NHS and a lot of time for the general practitioners who are more well versed in, urinary tract infections or skin conditions or medications or colds and coughs and flus rather than the MSK presentations, which is what we do. So that's where we're lucky. And I think that pain will always be a debate. It will never not be a debate. We'll never get all the answers. And that's something we have to live with and just get on with it and have these healthy discussions and debates. And debate is good, even us four here, I'm sure some people are thinking, oh, what's Faraz saying? I don't agree with him, but that's good. That's a good thing. It's healthy. And that's how we learn. So on that note, I'm gonna sign off because I have a few commitments with my children. So we'll wait for the next one. Can we get a picture before we go or something, Niels? Or have you got a few pictures or something?
Print screen. Yeah.
Yeah.
I have a nice. Oh, my print screen is not so nice. So let's do another one.
All right, ready? 3, 2, 1.
All right. That's a great one. I will send it to you. Thank you, Faraz. Very interesting. Also, your input and everybody's input, indeed. And if you want to sign off, you can just sign off and go out of these live streams.
Amazing. Well, thank you, guys, and have a lovely weekend. And we'll look forward to the next one in a month or whenever it's going to be.
Thank you. You too.
Take care, Bogdan. Take care, Cohen. See you, Niels. Thanks. Bye.
Bye.
Bye-bye.
Yeah, so this is. Oh, now we have a new set of. Let's do like this. Yeah, let's wrap it up. I think it's great to have different opinions, and we don't have to agree with everybody all the time, and it's fine. You have your own mind, you have your own experiences, and I think that is very important to keep in mind, indeed. Yeah, and you try to learn from everybody a bit and see what you can pick from everybody. And that's the main thing I think I would say for physios in general and human beings in general. All right. Well, thank you both, and thanks also to Charlie and Sinan. Unfortunately, it didn't work well, but next time it will hopefully be better. And thank you also both for your input.
Thank you.
Thank you too.
All right, let's end this stream. Okay. All right. Bye bye, everybody.
Bye bye.